Hi, everyone. Welcome to the LactFact podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Ann Aglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist at the University of Wisconsin School of Medicine and Public Health. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Today's LactFact comes from the updated American College of Radiology's appropriateness criteria for breast imaging during lactation. These guidelines were authored by the American College of Radiology panel on breast imaging and published in April 2026. In their introduction, the authors explain that many different types of breast lesions, whether physiologic, infectious, inflammatory, or neoplastic, can present in different ways during lactation. Therefore, the goal of imaging in the lactating breast is to identify suspicious findings as well as masses or infections that require intervention and minimize diagnostic delay for breast cancer. The guidelines stress that any new palpable abnormality or unresolved infectious symptom or clinically suspicious nipple discharge should prompt imaging assessment with biopsy as needed, and that imaging should not be delayed among breastfeeding women when clinically indicated. In addition, they state that the American College of Radiology and the American College of Obstetricians and Gynecologists advise that breastfeeding does not need to be interrupted after contrast administration for medically necessary nuclear medicine scans. Core biopsies are considered safe and effective in lactating patients, while complications like milk fistula or bleeding are rare. In this document, they divide up recommendations based on clinical scenarios, but before I review those, I want to share the different modalities that can be used for breast imaging. We all know about breast ultrasound and mammogram as the most common breast imaging methods. There's also digital breast tomosynthesis, also known as a 3D mammogram, which includes many more images to help detect hard-to-find lesions in a dense breast. Breast MRIs are becoming increasingly common to help screen high-risk patients and evaluate lesions. An MRI can be done in a few different ways. There are MRIs that are done with and without contrast, MRIs that are done just with contrast, and MRIs done without contrast. There's also an MRI without IV contrast abbreviated, and this is a shorter, more targeted MRI towards specific lesions. So breast MRI with and without contrast is considered safe during lactation. Studies show that less than 0.04% of the maternal dose of gadolinium is excreted into breast milk, and less than 1% of that is absorbed by the infant's GI system, which means that there's essentially no significant amount of exposure. And then finally, there's the sestamibi molecular breast imaging called sestamibi MBI. This uses a radio tracer called technetium-99 sestamibi with a brand name Miraluma. It's given IV and it accumulates in cancer cells more so than in normal breast tissue. This test is also helpful for people with dense breasts, and the breast does not have to be compressed as much during imaging as compared to a mammogram. So bearing in mind these options, let's go over some scenarios that are outlined in the guidelines. The first scenario is the lactating woman who's at average risk for breast cancer, who's 40 or older and needs breast cancer screening. Because early detection of breast cancer is more challenging due to the increased breast density associated with lactation, they recommend screening mammography as the primary modality for this group. And if needed, 3D mammography can help decrease the masking effect of dense breast tissue and improve lesion visibility. In addition, they recommend pumping or breastfeeding before imaging to improve visualization and patient comfort. The guidelines recommend adding breast MRI for lactating women of average risk who have extremely dense breasts, since that's been shown to markedly improve detection of cancers compared to mammography. In addition, the European Society of Breast Imaging now recommends MRI screening for women with extremely dense breasts, regardless of their overall risk for breast cancer. Whole breast ultrasound is not acceptable as first-line imaging for average risk lactating women over 40, and sestamibi MBI is not considered a screening tool for average risk breastfeeding women over 40 because of lack of evidence. So now let's talk about breast cancer screening during lactation for women who are younger than 25, but have a higher than average risk of breast cancer. They recommend for this group a brain MRI with contrast. An ultrasound would not be supported as screening, and there's no literature to support the use of mammography with IV contrast or MRI without contrast. The next scenario would be breast cancer screening for breastfeeding women who are 25 years or older who have a higher than average risk. So women with genetics-based risk of breast cancer at 20% or more, and those who are exposed to chest radiation at young ages are recommended to undergo annual breast MRI with and without IV contrast between the ages of 25 and 30 years of age, and annual mammography in addition when appropriate. If an MRI with and without contrast is performed once a year, then they could wait until age 40 for an annual 3D mammogram. If they're not having annual MRIs, then they should have annual 3D mammograms. These lactating women would also be eligible for an MRI with and without contrast abbreviated, which, as I mentioned, is a shorter MRI procedure. Breastfeeding women who are under age 30 with focal pain or a palpable breast mass are most likely going to have benign lesions. So for these women, the initial imaging would be an ultrasound because ultrasound can distinguish between cystic and solid lesions, and they provide good visibility. The risk of pregnancy-associated breast cancer in this population is 0.7 to 3.8%. 3D and diagnostic mammograms are not appropriate for first-line screening in women under 30 with a palpable breast mass because these modalities won't identify additional cancers beyond what ultrasound will detect. They recommend using these methods of imaging if the ultrasound finds a suspicious or indeterminate lesion that warrants further evaluation. The benefit of adding 3D or diagnostic mammogram would be to evaluate for calcifications or architectural distortion not seen on ultrasound, but they would be in addition to ultrasound, not as that primary screening tool. There's a different set of recommendations for lactating women who are 30 or older with focal pain or palpable breast mass. So this population has a higher risk of pregnancy-associated breast cancer compared to women who are under 30, and their risk is estimated to be 10 to 20 per 100,000 births in the first postpartum year. These tumors are high-grade hormone receptor negative and have a poor prognosis. So for this population, they recommend starting with either a diagnostic mammogram or a 3D mammogram, and ultrasound can be used for further evaluation. They do not recommend using breast MRI or cystine MBI for first-line imaging to evaluate focal breast pain or breast lesions because there's just not relevant literature to support it. So let's go on and talk about nipple discharges. And first, I want to distinguish between a physiologic and a pathologic nipple discharge. Physiologic discharge is typically bilateral. It's going to occur from multiple ducts. It's not going to be bloody, and it's expressed only upon manipulation. Whereas pathologic discharge is spontaneous, unilateral, and typically arises from a single duct. And the discharge can be either goopy, clear, or bloody. They also point out another normal discharge, which is the rusty pipe syndrome in the first 7 to 10 days postpartum. This is when milk is mixed with either rusty or pink-tinged blood in the early postpartum period due to fragile, highly vascularized ducts. So they put the limits on that for 7 to 10 days. So if the symptoms continue past that, imaging would be appropriate. For women under 30 with a suspicious nipple discharge, breast ultrasound is the recommended screening because the most common reason for suspicious nipple discharge at that age would be a benign intraductal abnormality like a papilloma or ductal ectasia, which an ultrasound could identify. A 3D mammogram should be added to further evaluate a lesion if it's found in ultrasound. For breastfeeding women with a clinically suspicious nipple discharge who are 30 to 39, they recommend either a diagnostic mammogram or a targeted ultrasound for initial screening. But then so it could be either for women between 30 and 39. But once women hit 40, for women over 40, the primary imaging modality would be a diagnostic mammogram. But they also mentioned that adding ultrasound can increase cancer detection by 26%. A breast MRI can provide further evaluation of lesions as well. They also mentioned that sestamibi MBI is being looked at as a possibly preferred mode of evaluating pathologic nipple discharge. In one study, MBI outperformed mammography and ultrasound and is safe during lactation. For breastfeeding women who have a suspected breast infection or abscess, regardless of age, ultrasound is considered the best initial imaging. Ultrasound-guided aspiration is also commonly done to evaluate and drain the fluid collection. If the ultrasound shows a lesion that's clinically suspicious, then it's recommended to add a diagnostic or 3D mammogram. There's no evidence to recommend MRI as an initial imaging test for women with suspected infection or abscess. So there you have it. That was a lot. The good news is that you don't have to memorize this. The appropriateness guidelines have colorful charts that allow you to find this information easily in their manuscript. My primary concern is the recommendation of an ultrasound for breastfeeding women who are under 30 who have either focal pain or palpable breast mass. They justify recommending an ultrasound as first-line imaging based on a retrospective cohort study of 167 lactating women who presented with a palpable mass who underwent targeted ultrasound as the first imaging modality. They found that the ultrasound detected all 5 of the cancers that were present among the 167 women with a negative predictive value of 100%. I feel more robust studies are needed to justify this approach because I've seen women under 30 with a delay in breast cancer diagnosis when the only imaging done for a mass or inflammation was ultrasound. So it behooves us as breastfeeding medicine specialists to be cautious here. And I would say that if you have a patient under 30 years of age who has a breast mass, who had a negative ultrasound, and still doesn't have a clear diagnosis, I would be an advocate and send them for a diagnostic mammogram. Hey everyone, thanks for listening. I encourage you to check out iAble at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits, which you can learn about at our website. I'll be back with another LactFact in a few weeks.